Hello, my name is Alexander Baxter. I'm an associate professor at the New York University School of Medicine, and I work at Bellevue Hospital in trauma and emergency radiology. I'm going to speak with you today about an approach to head trauma in the emergency setting. The goals that we have when imaging a patient who has or is suspected to have had head trauma are to primarily identify injuries that require urgent neurosurgical management. These will be extra-axial hematomas, intraparenchymal hematomas, compartmental shifts, cerebral swelling, and vascular injury. Our primary tool is the non-contrast head CT scan. It's the main study for acute head trauma and is usually combined with a cervical spine CT, since injuries to the cervical spine and head often occur at the same time. Repeat head CTs can be obtained 6 to 8 hours after injury to evaluate any changes in contusions or subtle hemorrhage that may be seen on the initial CT scan. We will get a CT scan for patients who have GCS of less than or equal to 13 or deteriorating neurological status, any patient with unequal pupils, and any patient with lateralizing weakness. Of course, mechanism of injury also goes into consideration as to whether or not to do a head CT scan. CT angiography is primarily used to detect blunt cerebrovascular injury. This can be seen in 2 to 3% of severely injured patients and in up to 18% of patients with defined clinical or imaging risk factors, which I will show you. The reason that this is so important is that anticoagulation prevents stroke in patients with blunt cerebral vascular injuries if it is detected. If it's not detected, patients can go on to have a stroke as they're recovering from their head trauma. Direct signs and symptoms of blunt cerebrovascular injury include arterial hemorrhage, gross arterial hemorrhage, cervical bruits in patients less than 50 years old, so not a bruit due to atherosclerosis, but due to vascular narrowing, an expanding cervical hematoma, any focal neurologic deficit, or a neurologic deficit out of proportion to the CT findings, and certainly anybody who has findings of a cerebral infarct on a CT done for trauma. Now, risk factors for blunt cerebrovascular injury, the injury itself may be asymptomatic, would be severe facial fractures like the Fort 2 or 3 fractures, skull-base fractures that involve the carotid canal, severe head injury, particularly diffuse axonal injury with GCS of less than 6, an associated cervical spine fracture or subluxation, and near-hanging injuries. MRI is generally not indicated in acute trauma. The reasons for this are that it's usually not readily available in the emergency room. Imaging times are prolonged often. It's sensitive to patient motion, and patients may have MRI-incompatible hardware. It is more sensitive than CT for traumatic axonal injury and contusion. However, if these are significant, these will be seen on a non-contrast head CT in the acute setting. It can be useful for detecting hemorrhages of different ages when one suspects non-accidental trauma in infants. Digital subtraction angiography, which used to be primarily a diagnostic method in trauma, is now really limited to treatments for vascular injury, which are usually detected by CT angiography. What would require treatment, pseudoaneurysms, carotid cavernous fistulas, and any kind of uncontrolled external carotid artery hemorrhage. Okay, so the approach to looking at a head CT and evaluating it is, in my opinion, probably best done from the outside in. So I start with the scalp, the calvarium, the epidural spaces, the subdural spaces, the subarachnoid space, and then finally the brain parenchyma and the ventricles and cisterns. This is the main anatomy of the covering of the brain. You can see in this cartoon that there is a bump over the scalp, a bump over the skull, which is a scalp injury. a fracture of the calvarium underneath that, and an epidural hematoma, which is located between the outer layer of the double-layered dura and the bone of the skull itself. So it's really below the equivalent of the periosteum of the bone. Now, the dura has two layers that come together, or that separate to form the dural venous sinuses. And below the inner layer of the dura and external to the arachnoid membrane is a compartment, which is the subdural space. And that is going to be a smooth space because it's bound by two membranes. Underneath that, between the arachnoid and the pia, is the subarachnoid space. And in that case, hemorrhage in that area can go into the sulci since the pia is tightly adherent to the actual surface of the brain. Notice that the falx is a dual-layered structure, and you can get a subdural hematoma between the layers of the dura, falcine subdural hematoma. Primary brain injury is what happens when the patient's head strikes an immovable object generally, include the following mechanisms: compression of the brain, stretching of the brain, rotation of the brain, and these can lead to cortical contusions, tearing of either epidural arteries like the middle meningeal artery, or subdural, traversing subdural veins. So you can get subdural or epidural hematomas. And you can also get, particularly with rotational acceleration, tearing of axons or traumatic axonal injury. Here is a cartoon showing both the mechanism of subdural hematomas and of epidural hematomas. Superiorly, there are the brain is stretched away from the dura, and bridging veins break and form hematomas between the arachnoid and the inner layer of the dura. You can also get contusions from compression and expansion of the brain. This is opposite the site where the patient strikes their head, which is called the coup site. And there you can get a scalp contusion, you can have fractures of the calvarium, and you can have hemorrhage from branches, usually of either the middle meningeal artery or the dural venous sinuses, that bleed into the space between the outer layer of the dura and the inner layer of the calvarium. So those are the primary injuries that we see immediately at the time of the head striking an object. Secondary injuries are the consequence of physiologic response to injury. And so you get cellular damage and necrosis, and then you get edema, so swelling. And the problem with swelling in the calvarium is that there's nowhere for the brain to go. So generalized swelling will compress arterioles on the surface of the brain and lead to ischemia. If you have a mass effect by an epidural hematoma, for example, in one part of the brain will herniate through the normal defects in the dura, including underneath the falx or across the tentorium, and that can also lead to arterial compression and ischemia. In this case, we have an example of external herniation through a calvarial defect, a large epidural hematoma with subfalcine shift, downward transtentorial herniation, and lateral transtentorial herniation or uncal herniation. You can also have tonsillar herniation in which the tonsils descend below the foramen magnum. So extra-axial injuries are everything outside of the brain parenchyma itself. And the way I would approach this is I look at these structures. So we look for scalp contusions and lacerations. We look for an underlying skull fracture. We look for arterial or venous epidural hematomas, subdural hematomas, subdural hygromas, and subarachnoid hemorrhage. So those are the types of injuries that we see outside of the brain. And we'll go through those now in greater detail. So scalp contusions should be obvious. That's the first thing to look for. It tells you where to look for other underlying injuries. But skull fractures is the next layer in. And 25% of severely injured patients will have no skull fracture. Therefore, plain radiographs are never indicated for diagnosis and have not really been done routinely for many, many years. Skull fractures are something we want to know about, and if we have a 3D reformation available, that can make them much easier to see than on axial CT images. So we generally will do 3D reformations whenever we see a skull fracture or suspect a skull fracture. Linear skull fractures can be associated with epidural hematomas because they can traverse the branches of the middle meningeal artery. Depressed skull fractures can be associated with contusions. Skull-base fractures, as I mentioned before, associated with blunt cerebrovascular injury, but also with cranial nerve injury and later CSF leaks. Now, this patient has a fracture of the frontal sinus. The important thing about frontal sinus fractures is that if there is a fracture of the posterior wall of the frontal sinus, one has to be concerned about development of meningitis because it's a non-sterile place that then comes in contact with the inside of the skull. Here is a 3D and a regular CT scan of a patient who had a moose head fall on him and had a focal skull fracture. It's a child, as you can see, the fontanelle is open, and underneath it a cerebral contusion. Okay, so the first thing we reach underneath the skull is the epidural hematoma. These are typically lentiform. They're located between the outer layer of the dura and the skull, the calvarium. 90% are due to tears of the middle meningeal artery. 10% are due to dural sinus disruptions. If you see a heterogeneous density, it indicates active hemorrhage, so bright and dark areas of blood. This is a typical epidural hematoma. There's a lentiform, hyperdense collection in the left parietal adjacent to left parietal calvarium, and if you look on the bone windows, you can see a linear fracture extending through the petrous temporal bone. It's part of the fracture that tore the middle meningeal artery that caused this arterial hematoma. And here's another example in a child. You can see a linear skull fracture, and you can see this focal hyperdense collection adjacent to the left parietal calvarium and brain. So those are arterial epidural hematomas. These can be associated with clinical signs of transtentorial herniation, particularly if they're large. You will often get ipsilateral pupil dilatation from interruption of the parasympathetic fibers. You can see ipsilateral oculomotor palsy, which gives a down and out appearance to the globe. You can see ipsilateral hemiparesis. There is often, with epidural hematomas, little or no direct brain parenchymal injury because the skull absorbs most of the energy. These have a relatively good prognosis if they are recognized and treated and evacuated. They typically occur on the site of impact, the coup, so these are a coup injury. Most are unilateral, most are supratentorial. A arterial epidural hematoma rarely crosses the coronal or lambdoid suture. They can cross the sagittal suture and the dural reflections. Now, venous epidural hematomas, which are much lower in pressure, are due to dural venous sinus disruption. Again, low pressure, they rarely expand significantly, but they can get large. They're typically the hematomas that are associated with the vertex epidural hematoma from disruption to superior sagittal sinus, or the posterior fossa from disruption of the transverse sinus, or the middle cranial fossa from disruption to sphenoparietal sinus. And these are two very typical venous epidural hematomas at the anterior aspect of the middle cranial fossae. On the image on your left, it's at on the left side, but the right side of the image, and opposite on the image on the right. Moving inwards, acute subdural hematomas are typically less than 1 to 2 days. These are due to shearing of cortical veins under acceleration, and these are the veins that traverse the subdural space. In contrast to epidural hematomas, these are usually associated with significant parenchymal injury and carry a high mortality, particularly in younger individuals who have relatively less room for the brain to absorb a adjacent blood collection. Poor prognostic indicators are either more than 2 centimeter thickness or more than 2 centimeters of midline shift. Acute subdural hematomas are hyperdense. They are crescentic rather than lentiform, and the hematoma is located between the dura, the inner layer of the dura, and the arachnoid. These are limited by the interhemispheric and the tentorial dural reflections, but they're not limited by the cranial sutures like epidural hematomas. Most are high in attenuation, some are mixed in attenuation. In patients who are severely anemic or have coagulopathy, they may be isodense to brain. Also, in patients who have had a subdural hematoma that's not acute, these can become isodense, and I'll get to that shortly. Here's a patient with a large left subdural hematoma. Notice it covers the entire hemisphere, so it's holohemispheric. It's more than 2 centimeters in thickness, and there's more than 2 centimeters of subfalcine shift. You can see both ventricles are well displaced across the midline. So this is a very poor prognosis. Here's another patient with a large right holohemispheric subdural hematoma. You can see, or actually you can't see, the perimesencephalic cisterns, which are completely effaced. There's both subfalcine and downward transtentorial herniation, and there's enlargement of the left lateral ventricle. So there's early trapping of the contralateral ventricle. Okay, subacute subdural hematomas occur or are identified between 2 days and 2 weeks. And they're characterized by subdural hematomas that have gradually decreased in density. And it's about 1.5 Hounsfield units a day. But in general, by 7 to 14 days, somewhere in there, the hematoma can be isodense to the cerebral cortex and can sometimes be very difficult to see. Here's an example of a patient with an acute subdural hematoma, the image on the left, and then 7 to 10 days later, you can see that it has decreased in density, although there is some persistent hyperdense clot. In this patient, there is a isodense subdural hematoma. Now, some portions of this have a crescentic shape to them, but that is common in chronic or recurrent subdural hematomas where the membranes form within the subdural space. So this is an isodense subdural hematoma with a little bit of midline shift. Here's an example of a patient with a fairly obvious right-sided near isodense subdural hematoma, but a more subtle one on the left. And MR can be helpful in distinguishing between or identifying subtle isodense subdural hematomas. Chronic subdural hematomas are greater than 2 weeks old. Typically, they have a homogeneous low attenuation if they're not complicated. You do get vascular membrane formation, which can increase the risk of rebleeding, so you may see areas of higher attenuation hemorrhage within a chronic subdural hematoma. Sometimes these can have a lentiform shape that will simulate an epidural hematoma. So here is a chronic subdural hematoma and another patient with areas of rehemorrhage in that chronic subdural hematoma causing these lentiform collections. Here is a patient in whom the clotting has completed, and so you can, and because they were on the lying on their back, you can have a parfait appearance where you have the more cellular elements forming or collecting at the dependent portions of the brain or the caldarium. And here is another example of a chronic subdural hematoma on the left and a isodense or subacute subdural hematoma, which was a rehemorrhage on the right. And again, the same patient a little while later had a subacute hemorrhage on the left and a remote subdural hematoma on the right. Subdural hygromas are due to injury or disruption of the arachnoid membrane without hemorrhage. They are CSF in attenuation. They're usually bifrontal, and they usually develop 2 to 4 days after a head injury. These can be indistinguishable from chronic subdural hematomas, but the timing usually tells you that it's a hygroma. These usually do not enlarge or require treatment. And here is an example of low-density subdural hygromas occurring 2 days after a fall and head strike. Okay, now moving inward from the dural membrane is the subarachnoid space between the dura and the arachnoid membrane. Traumatic subarachnoid hemorrhage is the most common cause of subarachnoid hemorrhage. That is, trauma is the most common cause of subarachnoid hemorrhage. They're usually associated with other cerebral injuries, but can be seen in isolation. Places to look for subtle traumatic subarachnoid hemorrhage are the ambient and interpeduncular cisterns, and MRI with FLAIR sequencing is highly sensitive for detecting small amounts of subarachnoid blood. And here is a patient with, on the image on your left, is a little bit of hyperdensity in the interpeduncular cistern. On the right, there is a bit of blood in the left lateral ventricle and in the left ambient cistern. Here is another example of traumatic subarachnoid hemorrhage involving the left perimesencephalic cisterns as well as the inferior aspects of the frontal lobe. And here's a patient with a small left epidural hematoma as well as frontal traumatic subarachnoid hemorrhage, and there could be some cortical contusion there as well. This is an example of MRI showing traumatic subarachnoid hemorrhage as well as a traumatic subarachnoid hemorrhage involving the cortical sulci. You see on the T1 weighted image on your left, the sulci are dark, but on the FLAIR sequence on the right, the sulci are increased in attenuation because there's blood in the CSF. There is a small frontal subdural hematoma as well. Okay, continuing into the brain parenchyma now, contusions and hematomas. These are typically cortical or subcortical hyperattenuation. They can be subtle on initial examination and enlarge 12 to 24 hours after injury. Hematomas can result either from direct vascular injury or hemorrhagic coalescence of petechial hemorrhages. Subacute hematomas can enhance peripherally and can sometimes mimic intracranial tumors. These are examples of where in the brain one typically sees cortical contusions at the anterior aspects of the temporal lobes, the inferior frontal lobe, the convexity, and the posterior aspects of the occipital lobe and the cerebellum. And that's due to the fact that the brain hits against these roughened surfaces of the skull base and calvarium there. This is a patient. The image on the left is the initial study, which shows some very subtle left inferior frontal hyperdensities that become more obvious at 24 to 48 hours. Again, a similar patient who has a small left inferior frontal contusion and a larger hemorrhagic parenchymal hematoma. This is a relatively acute parenchymal hematoma on the left. You can see there's a lot of associated soft tissue swelling. The image on the right is the same patient, but much later, and you can see that the hematoma resolves, leaving a slightly hyperdense rim that can be mistaken for a tumor if you don't know that there's been prior trauma. And here's another patient with extensive inferior frontal cortical contusions as well as a left anterior temporal cortical contusion. Traumatic axonal injury is due to high energy transfer mechanisms and usually associated with immediate loss of consciousness. And because of the differential density between gray matter and white matter, nerve axons can shear. The gray matter moves at a different rate than the white matter, tearing these fine neural connections. CT can be normal, or it may show associated tiny vascular injuries. More sensitive study is generally MRI using diffusion and flare and gradient echo sequences. These are the typical locations for traumatic axonal injuries, most commonly at the cortical gray-white junction, but with higher energy mechanisms, they can be seen in the basal ganglia and the corpus callosum. And Durée hemorrhages are a special case in which you get petechial and axonal injuries from herniation of the brainstem. This is a patient with subtle cortical junction traumatic axonal injury. And here's another patient with several of these. They all look very similar, quite subtle, but the thing that patients have in common is that they have generally immediate and severe loss of consciousness. Here's a patient with both a deep left cerebral peduncle traumatic axonal injury, as well as multiple cortical contusions and a small bifrontal subdural hygromas. Again, another patient with deep axonal injuries, and you can see on the MRI on the right, which is a gradient echo sequence, the microhemorrhage associated with these. Another example of petechial microhemorrhages in diffuse axonal injury. This patient has a callosal contusion or callosal axonal injury, which is easier to see on MRI. You can see there's some high signal in the posterior corpus callosum, both on the sagittal and on the coronal views. So those are the primary brain injuries that we see. Secondary injuries are due to traumatic dysautoregulation, brain swelling, and herniation. Again, large vessel infarcts can occur if the posterior cerebral or anterior cerebral artery are compressed with herniation. And the other secondary brain injury is infection, which can be seen in skull fracture or penetrating injuries. So here is a cartoon which I showed before, showing the different ways that the brain can herniate through the different compartments. And here is a patient with multiple left frontal and temporal contusions and effacement of the cisterns, left to right subfalcine shift, trapping of the right lateral ventricle, and complete loss of the perimesocephalic cisterns and generalized brain swelling. So these are secondary injuries. Here's another patient with a large left anterior temporal hematoma, left uncal herniation or transtentorial herniation, and trapping of the right lateral ventricle. Of course, the prognosis for this injury is not very good. This is one slice higher up showing the associated large left hollow hemisphere subdural hematoma and traumatic subarachnoid hemorrhage in the sylvian fissures and in the anterior interhemispheric fissure. This is a patient with a Durée hemorrhage. They have a large right temporal acute subdural hematoma and downward transtentorial herniation. And you can see in the pons is an area of hemorrhage, and that's due to stretching of vessels and rehemorrhage. This patient has a large left subdural hematoma, and they have loss of gray-white differentiation in the distribution of the anterior cerebral artery on the image on the right, and in the distribution of the posterior cerebral artery in the image on the left. And this is as well as trapping of the right lateral ventricle. This is due to arterial occlusion from subfalcine and transtentorial herniation. In this case, both the anterior cerebral artery and the posterior cerebral artery are compressed, leading to infarcts in those vascular distributions. This brings us to the conclusion of the lecture. Again, to summarize, the approach that I take is to start at the outside, looking for scalp injuries, the site of contact between the brain and whatever object it hits, and then go layer by layer until you reach the center of the brain. So the usual suspects in terms of traumatic injury are going to therefore be skull fractures, epidural hematomas, subdural hematomas, cortical contusions, traumatic axonal injury, and then the secondary consequences of injury, including subfalcine shift, transitorial herniation, and subsequent cerebral ischemia or infarcts related to vascular conclusions. Thank you for your attention.